Extreme temperature exposures, both heat and cold, is a concerning environmental health risk that are affecting a large number of individuals around the world. In the context of global climate change, the health burden is expected to increase. Those with certain chronic conditions, such as cardiovascular and respiratory diseases, are particularly at risk. Public health intervention is an important tool for us to manage these risks. Emergency risk communication is a public health intervention tool for this purpose. Examples are heat and wind chill advisories. Currently, the message is designed to target the general population and thus contain only the basic information about the risky exposure. It is initiated when, based on forecast, temperature is expected to cross an extreme temperature threshold. This study explores if we can tailor the emergency risk communication message to protecting those with chronic conditions exacerbated by outdoor temperature exposure, with the goal of reducing the overall health burden. More specifically, we used a nonlinear time series model to examine if extreme temperature levels are associated with increased relative risk. This model is appropriate because it captures a potential temporal delay between temperature exposure and health responses. Beside all-cause population health, cardiovascular, respiratory, renal diseases, and diabetes are also considered. They're commonly observed chronic conditions that have been linked to outdoor temperature exposure. We base our analysis on the mortality and morbidity data from Minneapolis-St. Paul Twin Cities metropolitan area, which consists of 7 counties and is home to about 3.3 million residents as of 2010. 6 thresholds corresponding to the bottom and top 3 percentile temperature values are considered as potential initiation thresholds. Results validate that using extreme temperature threshold to initiate broad emergency risk communication is appropriate. However, not all thresholds capture increased relative risk for specific causes. Extreme cold threshold captured increased relative risk for cardiovascular and respiratory diseases, and extreme heat thresholds capture increased relative risk for renal diseases. Emergency risk communication may be tailored for these specific causes and exposure combinations. Otherwise, it is an unlikely appropriate candidate for managing the health risks. Keep in mind that not having increased relative risks at extreme temperature levels does not necessarily mean there is no association between temperature and health. Instead of a classic U or J-shaped exposure response function, sometimes we may find maximum risk to correspond to moderately cold exposures instead of cold extremes, such as the case for cardiovascular morbidity. In this case, emergency risk communication may be a suboptimal choice. Other channels, such as patient engagement, should be explored. This study, in combination with others that investigate different risk factors, such as age and occupation, can bring epidemiology in service of personalized health. For more information, please find our paper published in the risk analysis. Thank you for watching.